Hi everyone. Let us talk about the tuning fork tests in this presentation. Tuning fork tests are an important topic from all the points of view, like even from the exam point of view, where you write the theory exam, this is important. They will ask you in Viva also. They will, and day-to-day practice also, it is going to be useful to you even if you do not take ENT. You will have a good idea what is happening, and if you take ENT, then this is like you have to do it in your day-to-day practice. Then in NEET PG also, they can really twist it in quite a difficult way to make the question, to make it difficult for the student to get the right answer. But if you get the basics right, the most important thing is to get the basics right. If you get the basics right, what is happening at the basic level, even if you twist the question in a difficult way also, it can be answered. So from the theory exam point of view, the questions that have been asked previously are the tuning fork test, what is Rinne's test, what is false negative Rinne, what is Weber's test, and what is Gilles test. Okay, so here we have a patient who is coming to you with hard of hearing. He says, I cannot hear well in the right ear, or he can say, I am not able to hear in both the ears. So you first examine the external auditory canal. What is there? Is there any wax or whatever, fungus, etc.? Then you examine the tympanic membrane. Then you have from there on, you have to know what is happening to the middle ear conductive pathway and what is happening to the sensorineural pathway. To know, perform the tuning fork test. The tuning fork test, the various tests that have been described are the Rinne's test, Weber's test. These two are basically the go-to tests for any ENT surgeon. Okay, these absolute bone conduction test, Schwabach's test, Bing test, and Gilles test, these are more from the theoretical point of view, but having a good knowledge about them will help you to crack the NEET PG exam. Okay. Now, coming to what are the uses of the tuning fork test? Why do we do the tuning fork test? With the tuning fork test, we will come to know where is the site of the lesion and what is the approximate degree of hearing loss. So to know the site of the lesion and the degree of the hearing loss, the tuning fork tests are used. Which tuning fork tests are most commonly used? The most commonly tuning fork test, the go-to tuning fork test is the 512 Hertz. So 512 Hertz is the most commonly used tuning fork, okay, when we perform this tuning fork test. Why? Because it is better heard. Frequencies lesser than 512 Hertz have a more vibration sense. So in addition to the sound, patient is going to have the vibration, which is going to be difficult. Will make getting the correct response from the patient a little bit difficult. So vibration sense will be more in less than 512 Hertz, like 256, 128 Hertz. They are used mostly in the neurology department for checking the vibration sense. Above 1000, above 512, that is 1024, these tuning forks, they dampen very fast. The moment you you vibrate it on your elbow or on the sole of your foot, within a very few seconds, they will get dampened. So patient needs some time. For the first time the patient is listening to this, for him to understand what is happening, it takes some time. So if it dampens very fast also, it will be very difficult to get a response from the patient. So 512 is the most commonly used. Less than 512 of a vibration sense, more than 512 has dampens very fast, so it's less commonly used. With the tuning fork, what do? We test for air conduction and bone conduction. Now, how do we do air conduction? Air conduction, we take a vibrating tuning fork. How do you vibrate a tuning fork? You vibrate it on the elbow or on the sole of your foot, sole of your shoe, and then you place the vibrating tuning fork 2 centimeters in front of the pinna. So this is how you are vibrating the tuning fork and place it in front of the pinna. When you vibrate the tuning fork and place it in front of the pinna, the pathway that these sound vibrations pass will be the pinna, the external auditory canal, then the tympanic membrane vibrates, then the ossicular chain vibrates, and then the foot plate of the stapes. Till the foot plate of the stapes is what we have the conductive pathway. Beyond that, we have the sensorineural pathway. What are they? They are the organ of Corti, okay, then the eighth nerve, then the auditory pathway in the brain, and finally the auditory cortex. Okay, this one from the organ of Corti to the auditory cortex is what we call the sensorineural pathway. So when a patient says, I can hear this tuning fork well, when you place it in front of my pinna, he is telling to you, he's conveying to you that my conductive parasensory and neural pathway, all of them are functioning properly. So by default, somewhere in the subconscious mind, when we say air conduction, we think only conductive. We don't really focus on the sensory and neural pathway. We say air conduction is a measure of conductive pathway. No. What is the use if the pathway is working very well, if the cochlea is not working, if the eighth nerve is not working, whatever the sound that you can hear here, that the sound is coming till the footplate of the stapes, if that is not being transmitted to the cochlea, to the eighth nerve and to the auditory pathway, there is no use. So conductive pathway is working and the sensory and neural pathways are working, only then the brain is able to perceive. So air conduction, do not make the mistake of saying that it is a measure of the conductive pathway. It is a measure of all the three pathways. Okay, so pinna, external auditory canal, tympanic membrane, ossicles, footplate of stapes, and then the cochlea, that is the organ of Corti, then the eighth nerve, then the auditory pathway, and goes to the brain. So air conduction is a measure of the three pathways: conductive, sensory, and neural. Now bone conduction. Bone conduction, what do? We take the vibrating tuning fork and place it directly over the mastoid, or the patient's mastoid. Here we are placing it over the patient's mastoid. So what is the pathway that this vibrating tuning fork, the sound vibration from the tuning fork pass through? So it doesn't go through the tympanic membrane, pinna, external auditory canal, tympanic membrane, ossicles, and footplate of stapes. No, it doesn't go through all this. Okay, it directly stimulates the organ of Corti. It directly stimulates the cochlear fluids and the cochlea, the hair cells over the organ of Corti get stimulated, and that vibrations are transmitted through the eighth nerve to the auditory pathway to the auditory cortex. So that is what is happening. So vibrating tuning fork vibrates the skull, which vibrates the tuning cochlear fluid, which stimulates the organ of Corti. From there it goes to the eighth nerve, auditory pathway, and auditory cortex. So bone conduction is a measure of only, now only is an important word here, only the sensory and neural pathways, only sensory and neural pathways. It is not measuring or not in any way giving you any information about the air conduction pathway, about what is happening in the external auditory canal, tympanic membrane, ossicles, or in the middle ear. It is not giving you any information. It is giving you information that sensory neural pathways are fine. If you place it on the mastoid of the patient and the patient says, I can hear, it means that the sensory neural pathways are working fine. So the point that we are trying to put across is the sensory and neural pathways are common to both the pathways. The sensory and neural pathways is common to the bone conduction pathway and the air conduction pathway. Air conduction, you have the conductive pathway in addition. Okay. Then, now this slide is going to make a difference whether you really understand Rinne's test or not. This slide will make a difference. So in both air and bone conduction, there is a change in the medium. How is there a change in the medium? In the external auditory canal, the tympanic membrane, the middle ear. Okay, middle ear is having a eustachian tube connected to the nasopharynx, and then you have the cochlea, and then you have the eighth nerve. Okay, so when the sound is passing through the air conduction pathway, it is coming and finally causing a movement in the cochlear fluids, and that is causing stimulation of the organ of Corti. Okay, so here there is a change in the medium. Here this is passing through the air. Okay, and finally here there is fluid, so there is change in the medium. Suppose you place it on the mastoid and the vibrations are going directly to the cochlea. Here also the sound vibrations are going through the bone, and finally they are stimulating from the bone. They are stimulating the cochlear fluids, that is the organ of Corti. So there is a change in medium in both air conduction and bone conduction. In bone conduction, you are not cochlear fluids. The vibration has to pass through the skull to stimulate the cochlear fluids. Okay. In both there is stimulation of the there is stimulation of the cochlear fluids, and both there is a change in the medium. But what is the really different thing about the air conduction is it is passing through the middle ear transformer action. So the sound vibrations are passing through the middle action. The middle ear is not just acting as a conductive pathway. The middle ear is increasing the sound of lesser force and greater amplitude at the footplate of the stapes. It is changing into greater force and lesser amplitude. So this is what is happening only in the middle ear transformer action. So that is not happening in the bone conduction. So because of this, the sound that is coming through the air conduction pathway is heard louder and longer compared to the bone conduction, only because there is a transformer action of the middle ear occurring in the middle ear. So the middle ear transformer action is increasing a sound of lesser force and greater amplitude to greater force and lesser amplitude. So that is why the air conduction is louder. Air conduction is heard longer than bone conduction. And air conduction is what we usually use in our day-to-day things. Okay. So what is Rinne's test? Rinne's test. So Rinne's test, the procedure. How do you perform the procedure? You take a vibrating tuning fork and you place it first on the patient's mastoid. First on the patient mastoid. You tell the patient, when you stop hearing, you tell me. Okay. After he tells that I can't hear it any longer, you place it in front of the pinna. So first you place it on the mastoid, then you place it on the pinna. When you place it on the pinna, if he says I can still hear it, which means that air conduction is longer. Okay. So air conduction is longer. So air conduction is better than bone conduction, which comes to Rinne's positive. Okay. Why is positive? Okay, so a vibrating tuning fork is first placed on the patient's mastoid, then placed on the in front of the pinna. So the patient is asked, can you still hear it after it stops at the mastoid, which means that he can hear it after the vibration has stopped at the mastoid. So he's hearing it for a longer duration. Or you can ask, I'm placing it on the mastoid and then I'm placing it in front of the pinna. Which do you feel is louder? Then he will say, yeah, in a normal patient, he will say, I can hear the air conduction. That is, when you place it in front of the pinna, I can hear it louder. So it means air conduction is better than bone conduction. Okay. So this, when the person says that the air conduction is better than bone conduction, he's saying that the air conduction is either longer or louder than bone conduction. Then we say it is positive. Rinne is positive. Usually for a medical student, when we say positive, we associate positive with disease. But here in this case, do not associate Rinne's positive with disease. Rinne's positive means normal. In any person, the air conduction is always better than bone conduction, because this is what we use to talk to each other. We do not use any bone conduction method to listen to each other. We use the air conduction method. We talk to each other through the air. So air conduction is better than bone conduction, and this is what we usually use, and this is what happens to all of us. So air conduction is better than bone conduction. Air conduction. So Rinne is called positive. Okay. Now Rinne is called negative when the bone conduction is longer or louder than air conduction. When the bone conduction is better than air conduction. So this is what is diseased. So this does not happen in day-to-day life. Okay. So bone conduction is better than air conduction. Then you say, then Rinne is negative. Rinne is negative is associated with disease. Rinne is positive is normal. So this is also confuses a lot many of people. So just keep on repeating or keep on talking to each other. You can explain to each other. Once in a while you can think, okay, Rinne is positive means normal. Rinne is negative means it is having disease. Okay. Rinne is normal. That happens to all of us easily. Air conduction is better than bone conduction. Disease means it is the opposite. Bone conduction is better than air conduction. Okay. So when air conduction is better than bone conduction, Rinne is positive. We already talked. It is having two possibilities. One is the normal ear. Okay. So in normal ear, Rinne is positive. It is also positive in sensorineural deafness. Now this is, we'll also talk why also. This also happens, Rinne positive, that is, it is also associated with disease, that is sensorineural deafness. RINI is positive not only in normal people but also in disease, that is in sensorineural deafness. Air conduction greater than bone conduction, that is positive in sensorineural deafness. Now that is the question. Here the common pathway, that is the sensorineural pathway, is defective. That is the sensory and neural pathway is defective in sensorineural deafness. Okay. So both air conduction, because it is using the sensorineural pathway, it is going to decrease. Conduction is also using the sensorineural pathway, so it is going to decrease. But in conductive pathway, what is happening is you have the transformer action of the middle ear. The transformer action of the middle ear will increase the sound capacity. So the sound that is presented to the cochlea, is more when the sound is coming to the air conduction pathway than the sound that is coming to the bone conduction pathway. Because it's a transformer action, so it is presenting more sound to the cochlea. So even in sensorineural deafness, air conduction is better than bone conduction. I know this is confusing, that's why I myself couldn't really make perfect sense of it. So I came up with an analogy. So I hope you can understand with this analogy how to make RINI understandable. Okay. Now we will use some, this is an analogy, you cannot take it literally. Okay. So normal ear air conduction, what happens? So suppose this is a tuning fork and it is producing 60 units of sound. Just imagine that this tuning fork is producing 60 units of sound. This 60 units of sound is passing through the pinna, through the external auditory canal, and then it comes to the transformer action, that is the middle ear, where the transformer action of the middle ear occurs, and that is increasing the sound. It is not presenting the sound as it is to the cochlea. It is increasing the sound. It is making the sound of greater force, from lesser force to greater force. So just to understand, let us imagine that it's increasing the sound by 40 units, another 40 units. So it is increasing from 60 units to 100 units. So because of the transformer action, the sound that was actually 60 units, because of the transformer action, it has become 100 units. And this 100 units is presented to the cochlea. The cochlea doesn't do anything, it just transmits it to the cochlear nerve, which transmits it to the brain. The brain, what does it perceive? It perceives it as 100 units. So when the tuning fork is placed in front of the pinna, when we are testing the air conduction, which is passing through the middle ear transformer action, the brain is perceiving it as 100 units. Okay. Now, normal ear bone conduction, what happens? So here we are placing the same 60 units of tuning fork on the mastoid. Okay. So tuning fork is producing 60 units of, there is no transformer action. Okay. This 60 units is presented to the cochlea. The sound directly goes from the cochlea to the brain. The brain perceives it as 60 units. Okay. In the previous air conduction, what did we say? The brain is perceiving it as 100 units. Here, what did we say? Here the brain is perceiving it as 60 units. 100 is greater than 60. Air conduction is better than bone conduction. So RINI is positive, which happens in normal people. So this is exactly why the bone conduction, air conduction is better. We have a tuning fork. Yeah. We have a tuning fork and that is producing 60 units of sound, and that sound is increased to 100 units and that sound is presented to the brain. Then we can understand that air conduction is better than bone conduction. Okay. Now in sensorineural deafness, sensorineural hearing loss, what happens? Sensorineural deafness means the capacity of the cochlea has decreased. Let us imagine that the capacity of the cochlea has decreased by 40 units. Its capacity to transmit sound has decreased by 40 units. So now in the air conduction, we are taking the same 60 units tuning fork and place it in front of the pinna. That is, we are testing the air conduction. It is going through the pinna, external auditory canal, middle ear transformer action comes in the way, and it is increasing the sound to 100 units. It is increasing the sound from 60 units to 100 units. But what is happening? The cochlea has got damaged by 40 units. So 100 minus 40, 60 units. So only 60 units it is able to transmit, which is transmitted through the eighth nerve, which transmits to the brain. The brain perceives it as 60 units. Okay. So a 60 units tuning fork, which in a normal person, if the cochlea is normal, it should have perceived it as 100 units. Here it's perceiving it as only 60 units. Okay. Now, same in the bone conduction, again we are taking a 60 units tuning fork and putting it on the mastoid, that through the transcranial transmission of sound occurs and the cochlea gets stimulated. But the capacity of the cochlea has got damaged by 60 units. So 60 minus 40, its capacity has got damaged by 40 units. So even if you place a 60 unit tuning fork coming to the cochlea, it can only transmit 20 units of sound. So when you place it on the mastoid, that's the bone conduction, the brain is perceiving it as 20 units. So here when you place it in front of the pinna, the brain is perceiving it as 60 units because thanks to the transformer action. Here, because there is no transformer action, the capacity of the cochlea has gone down by 40 units, it is perceiving as 20 units. So you can see here, it is air conduction is better than bone conduction because 60 is greater than 20, air conduction is better than bone conduction. This is why in sensorineural hearing loss also, in addition to normal people, air conduction is greater than bone conduction. So Rini is positive, that is air conduction is greater than bone conduction in normal people and patients with sensorineural hearing loss. Okay, this occurs only and only because of the transformer action of middle ear. Because even in a sensorineural case, when the sound is passing through the transformer action, it is increasing its sound. Okay, if you can remember the 60 units, 100 units, and it's deficient by 60 units, for 40 units, its capacity has come down by 40 units, you can understand this. Okay, now we are coming to Rini negative. When you say Rini negative, it means bone conduction is greater than air conduction. Here also there are two possibilities. Rini is negative in conductive hearing loss. Conductive hearing loss means when there is a problem in the external auditory canal, when there is a problem in the tympanic membrane, when there is a problem in the middle ear or the ossicles. Till here there is conductive pathway and there is some problem here. So it is happening here. And also in severe sensorineural hearing loss on one side, when we call it as false negative Rini, we will come to that. Okay. So there are two possibilities. In Rini positive also there are two possibilities, normal and sensorineural. In Rini negative also there are two possibilities, conductive and severe sensorineural hearing loss on one side. So here is a patient with decreased hearing is coming to you and he says that when the tuning fork is placed on the mastoid, I can hear it louder than when you place it over the pinna, which means the bone conduction is longer or louder than air conduction. We say it is conductive deafness. Why? Because in conductive, when it says the bone conduction is good, which means the sensory neural pathway is good. So the defect has to be in the conductive pathway. Okay. When we say bone conduction is good, it means that the sensory neural pathway is good, which means by default, by understanding, we understand there is a problem in the conductive pathway. So there is a conductive deafness. So let us understand it by that same analogy. Again, we have as the same tuning fork, it's producing 60 units of sound and you place it in front of the pinna. But there is some conductive deafness, some defect in the conductive apparatus. It has got damaged and there is no transformer action. Transformer action is also gone. So the transformer action, conductive apparatus is not working, means the transformer action is also not working. So this conductive apparatus has got damaged by 30 units. So 60 units of sound, transformer action is also not working properly. So it comes to 30 units of sound. 60 minus 30, it got damaged by 30 units, right? So 60 that we have presented in front of the tuning fork, because of the damage to the conductive apparatus, only 30 units are being presented at the footplate of the stapes, presented to the cochlea. The cochlea transmits that as 30 units, the brain perceives it as 30 units. Now the same thing, let us put it on the mastoid. Let's put the same 60 units on the mastoid. Here we are bypassing the conductive apparatus, we are bypassing the transformer action. So we place it on the mastoid and the vibrations go to the cochlea. The cochlea gets those 60 units directly and that 60 units is transmitted to the brain. The brain perceives it here as 60 units. Here there is no transformer action and also there is the conductive apparatus has got damaged. So because of these two things, air conduction it's only 30 units, but bone conduction it is 60 units. So bone conduction is better than air conduction. 60 is greater than 30. Okay. So bone conduction is greater than air conduction this is conductive hearing loss. Conductive hearing loss, so Rini is negative. Okay, the air conduction is better than bone conduction, sensorineural hearing loss. Okay, conductive apparatus has got damaged by 30 units and the transformer action is not working. So this is why in conductive hearing loss, we say the bone conduction is better than air conduction because the transformer action is not working properly and it is not able to transmit the sound properly to the cochlea. Now, a patient is coming to you with severe sensorineural hearing loss on one side. This is where it gets a little bit complicated. Severe sensorineural hearing loss on one side means severe sensorineural loss, greater than 70 decibels, greater than 80 decibels of hearing loss. Not only is it a hearing loss, it is a hearing loss of the sensorineural pathway. We are not talking about conductive pathway. Okay, conductive, whatever it is, severe or mild, you will always get RINI negative, bone conduction better than air conduction. In severe sensorineural on one side, that person cannot hear air or bone conduction on that side. Suppose the right side has got damage, sensorineural damage, severe sensorineural damage of greater than 70-80 decibels. That side, neither the air conduction is going to pass through because the cochlea is not working here properly, neither the bone conduction is going to pass through. Okay, nothing is going to pass through to the brain. The brain will not perceive anything, whether you put it in front of the pinna or you place it on the mastoid. Okay, on one side, nothing is going to pass through to the brain. But what happens on conduction test? We are placing it on the mastoid. When you place it on the mastoid, there is vibration of the whole of the skull. And that vibration of the whole of the skull, there is transcranial transmission of sound. So when you are stimulating the right side, through the skull, the left side cochlea also gets stimulated. Right side is not able to send anything to the brain, but the left side is normal. So the cochlear fluids vibrates and that goes to the brain. Okay, that goes to the brain. So when you place it on the mastoid, that brain perceives that I can hear something. So the patient says, I can hear something. Okay, patient hears. Patient responds to bone conduction, but not to air conduction. So what do you feel? You will see the bone conduction is better than air conduction. And you say RINI is negative. But it is not conductive deafness. Okay, that's why it is not bone conduction. The involved ear is not better than air conduction here. When we say RINI is negative, on the right side we say RINI is negative. Right side is having severe sensorineural hearing loss. We feel that bone conduction is greater than air conduction. You are giving this message. You are writing it on the paper. You are writing it in your exam, saying that bone conduction is better than air conduction. But is the bone conduction better than air conduction here? Bone conduction, there is severe sensorineural hearing loss. Bone conduction is not better than air conduction. Air conduction is using all the three pathways: conductive pathway, sensory, and neural pathway. Okay, it's all using all the three pathways. Okay. Bone conduction, air conduction is using all the three pathways. Bone conduction is using only sensory and neural pathway. So bone conduction is not better than air conduction, but we feel, because the patient, when you place it on the mastoid, he says bone conduction I can hear. So you say bone conduction is better than air conduction, but it's not real, not happening in the real life. So we say it is false negative RINI. You are getting a negative result, but it is not correct. So we say false negative RINI. False negative RINI happens in severe sensorineural hearing loss on one side. Okay. How do you come to know whether it's a false negative or true negative RINI? We do a Weber's test. We'll come to the Weber's test, but if suppose there is severe sensorineural hearing loss on the right side, if you place a Weber's test, it will get lateralized to this ear, because this is a bone conduction test. This side he is not able to hear anything. Here he will be able to hear normally. So Weber is lateralized to the left, but the disease is in the right. Okay, so left side, that's how we'll come to find out that the left side cochlea is working, right side is not working. Okay. So this is when you have multiple combinations, then it gets a little bit complicated. Okay, so in severe sensorineural hearing loss on one side, just to sum it up, a patient is having right side severe sensorineural hearing loss, not able to perceive 70 to 80 decibels, severe hearing loss on the right side. The nerves have got damaged. Let us say the cochlea has got damaged. Okay, you take a tuning fork and place it in front of the pinna. Because there is so much of hearing loss from the pinna, from the air conduction route, when you place it in front of the pinna, he says, I cannot hear anything. When you take the tuning fork and place it on the mastoid, the right side cochlea is not getting stimulated. But because there is transcranial transmission of sound, the left-sided cochlea will get stimulated. And the patient says, yes, I can hear. Okay, the brain is perceiving it. The patient can perceive it. Brain says, I can hear. So what do you feel? You feel that the bone conduction is better than air conduction. You say the patient is having conductive hearing loss, right? Bone conduction is greater than air conduction means conductive hearing loss, right? But there is no conductive hearing loss on the right side. There is severe sensorineural hearing loss. So it is giving you a wrong impression. So then you say that it is false negative RINI. Suppose this patient, right-sided, he had severe conductive hearing loss, let us imagine, then if you place a Weber's test, you place a tuning fork in the center, to the right side. Now when we come to the Weber's test, we'll talk about it. It will be coming to the right side, but it's coming to the left side. So because the left-sided cochlea is functioning, that is how you try to differentiate. When you're having a doubt, the patient is having false negative reading, you confirm it with a Weber's test. Now coming to, again we are going to use the same analogy. So the right side ear is having severe sensorineural hearing loss, and we are testing the right ear. We take a 60 units tuning fork and place it in front of the right ear. It goes through the pinna, external auditory canal, and the middle ear transformer action is increasing it to 100 units. That 100 units is presented to the cochlea. But what happens? Cochlea is gone. The total power capacity of the cochlea is gone. So there is no information that is passed on to the eighth nerve, no information to the brain. The brain says, I cannot hear, air conduction is 0. Okay. Now you take the same tuning fork, 60 units, and place it on the mastoid. That information goes to the cochlea. But the cochlea on the right side goes to the right-sided cochlea. The right-sided cochlea, it is not functioning. Again, there is no transmission through the eighth nerve, no transmission to the brain. Brain says, I cannot hear, bone conduction is 0. But what happens? When you place on the mastoid, through the skull, it goes to the left cochlea. And the left cochlea is normal. So the left cochlea perceives it as 60 units, same 60 units. And that is passed on through the eighth nerve, that is passed on to the brain. The brain here perceives it that I can hear 60 units of sound when you place it on the mastoid. All this happens at the same time, right? The vibrations pass to the right cochlea, the vibrations pass to the left cochlea. Right cochlea is gone, no transmission, but the left cochlea is able to transmit the sound. It goes to the brain, brain says I can hear. So then you say bone conduction is better than air conduction. But it's not so. It's not that the patient is having right-sided conductive hearing loss. You're getting a wrong information. So it is false negative Rini. Okay. Now, what information does Rini's test you? Rini will become negative only air-bone gap. That means there is a minimum deafness, conductive deafness. Conductive deafness, when you say air-bone gap, it means a conductive deafness of 15 to 20 decibels. Only when there is a deafness of 15 to 20, it can pick it up. That's why it is not a very sensitive test. Weber's is very sensitive. It can pick up 5 decibels also. But Rini's can pick up only if the deafness is more than 15 to 20 decibels. Okay. Now, how do you use a Rini's test to get the degree of hearing loss? Okay. When the is negative, so this is a patient with conductive hearing loss. Okay. It's a patient with conductive hearing loss. Then Rini is negative. That is, bone conduction is greater than air conduction for 256 Hertz. But it is positive for 512 Hertz. Okay. But it's positive. That is, air conduction is better than bone conduction for 512 Hertz. Which means that Rini is negative for 256 Hertz. It means that the air bone gap is 15 to 20 decibels. Okay. Now, now you're using all the 3 tuning forks here. Now the Rini is negative for 256 and 512. That is, bone conduction is greater than air conduction for 256 and 512. But it is positive for 1024. Here air conduction is better than for 1024. The patient is saying it is normal. Normal from the air conduction better than bone conduction. That is for the normal people. Then you say, because both 256 and 512 it is negative, you say the air bone gap is 30 to 40, that's 45 decibels. There is a conductive hearing loss of 30 to 45 decibels. Suppose the Rini is negative, that is, bone conduction is greater than air conduction for all the 3 tuning forks, then the hearing in the range of 45 to 60 decibels. Okay, so this is what the use of using all the 3 256, 512 and 1024, all the 3 tuning forks. It is negative with only 256 but positive with 512, then 15 to 20 decibels. It is negative with 256 and 512, then 30 to 45 decibels. If it is negative with 512 and 1024, it is 45 to 60 decibels. Okay, so this I understand this is a bit of a complicated topic and you won't get it in the first attempt. You will have to think about it, probably even imagine a few scenarios, then you will be able to understand it. Try to explain it to your friends. Let them explain them back to you. Have a gap of 15 to 30 days and again revise it. Then you will be able to get it. I tried my best to make it as easy as possible. Thanks for the patient listening.